Good afternoon. Thank you all for staying for the last two talks. We promise not to disappoint for those of you who are stalwarts. I have the pleasure now of introducing Gary Gottlieb, who's the Chief Executive Officer at Partners HealthCare, my center's parent organization. Gary was recruited to Partners in 1998, at that time to oversee our development of our mental health network. He's a psychiatrist by training. And he has taken various positions throughout the organization, including being the president of the Brigham and Women's Hospital, and then since January of 2010, the president and CEO of the whole enterprise, Partners HealthCare. It's a privilege and pleasure to work for Gary for many, many reasons. He's known for his intense support of innovation, thus that our center's been able to flourish under his leadership. He's also known, however, for reading the big picture and steering this enormously complicated large ship called Partners towards new territory, which has been the taking of risk, the lowering of our cost structure, all tremendously difficult things for a person at the top of such a large, complex organization, and we're in the middle of it, and it's going quite well under his stewardship. The other thing I'll say about him is he's known for and is quite impressive at his ability to go from his level, which is, of course, very high, very quickly, very deep on any topic, and go toe-to-toe with anyone who's a subject matter expert in that given topic. Thus, whenever I meet with him, it's always a fun, challenging, back-and-forth conversation about the role that connected health can play in the future of our organization. So we're pleased to have him here to talk about how Partners is dealing with this new territory that we're in, and please warmly welcome Gary Gottlieb.
Thank you, Joe, and thank you all so much for joining us for this really wonderful conference. I think that reflection of the great work that Joe and the Center for Connected Health and all the folks here have done over these past years in bringing together such a wonderful group of people from our industry who are looking to figure out what the tools that we need to have to be able to move ourselves forward in the healthcare enterprise. I'm going to talk with you a little bit about the Partners healthcare system, the challenges that we face and what it is that we're attending to do, and how it is that connected health creates a set of tools for us that are critical in our ability to be able to transform medicine. The Partners healthcare system, which is anchored by the Brigham and Women's and Mass General hospitals, was founded just about 20 years ago, but its principles go back as long as 200 years. And its purpose is first around patient care. And that's truly to bring the best and the brightest to care for the sickest and the neediest among us, to use science to inform that care, to use care to inform science, to train the leaders of the future of medicine and many extraordinary providers and scientists who frankly have made us and have been really the talent base and really the core of our essence, and to invest in our communities here in Boston, in Revere, in Chelsea, Jamaica Plain, and in faraway lands like in Rwanda and Haiti, Lesotho, and in South Africa. So how does one really establish and how is one able to maintain that mission in the context of a transformative world? We see an environment that is loaded with substantial cost pressures as healthcare costs are crowding out other investments. The marketplace is starting to focus on a requirement for increased accountability and a requirement of increased price sensitivity. So the insurance buffer that has existed for an extended period of time that have essentially allowed almost endless elasticity of price will now be limited. And additionally, starting to pay for value, to give rewards that are specific to outcome as opposed to only for transactions or units of service. And additionally, that's created a higher degree of competition. And frankly, with the Affordable Care Act, with Chapter 224 here in Massachusetts, increased price transparency will make it very, very difficult not to be accountable in the long run overall, either to referral sources who become price sensitive or to individual consumers. So we have believed from the perspective of our overall strategy that we need to control much more of our own destiny. Being anchored by two large referral enterprises who have the largest biomedical research enterprise in the country, clearly transaction-specific prices are going to be challenging to us. and the ability to coordinate care in a more effective way is essential. We can't find ourselves at the end of the feeding chain if we are going to ultimately be able to support that spectacular mission into the long run. So we feel that we need to own a higher degree of responsibility for what it is that we do financially, and that we need to be able to figure out how to get the right care in the right place using coordination to reduce total medical expense rather than focusing just on transactional prices where it would be harder for us to compete. Partners has the full spectrum of care, and we have since we started and have added to it. We have an acute care group of hospitals that are anchored by the 2 academic medical centers, a set of community hospitals in and around our region, a large network of primary care doctors who are truly the front end, but also we have invested in areas that the rest of the marketplace has forgotten. In-home services, rehabilitation care, long-term acute care, psychiatric services, pediatric services, and substantial perinatal care, and community health centers. We own a half a dozen of them, and we have responsibility or relationships with another 15. And in that context, the question is, how does one transform them from a set of related silos, which is what a fee-for-service environment promotes, to have a higher degree of coordination that's all around patients so that they can be used seamlessly? That's where the Center for Connected Health, I assure you, comes in. So, we have had a strategic vision that we've laid out, and that is that, one, we will embrace the notion of population health. The notion, as Greg Meyer discussed with you yesterday, moving away from fee-for-service medicine, getting prepaid and taking responsibility for a population on a per member per month amount, or sharing with the insurers or government some risk associated with trend in the increased costs associated with care, and being able to have to deliver on quality as part of the prices overall. That means developing a network, empowering physicians and other providers to be very, very close to where people live, being able to allow them to have perfect information and to create seamless care between them, their community hospitals, and if necessary, the academic medical centers who can provide expertise either instantaneously or when necessary further away. At the same time, we have 2 large academic medical centers who solve problems that aren't routine. And those non-routine problems need to be able to be provided efficiently as well. So we need to be referral sources for many, many providers here and throughout the world who in fact need to have special problem solvers, special capital, and special intellectual prowess. And balancing those is a challenge because if one sits in a passive fee-for-service world, essentially one's basically trying to attract transactions or discharges. If one's moving in a population health world, one is trying to figure out around the patient how to optimize the overall experience, prevent adverse outcomes, and at the same time providing referrals is challenging. And much of the academic medical center is built off of specialty medicine. The greatness of training, much of the science is leveraged from specialists who obviously are ultimately become costs as opposed to revenues in a population managed world. So since 2011, we've done a number of things to try to change the paradigm, to change the way in which we've been paid. We reopened all of our commercial contracts and in fact took lower prices than were promised to us in the existing years in the contract, giving back about $345 million to the market over a 4-year period of time. We moved our contracts where essentially our primary care doctors were involved as much as we could into some kind of risk contract so that we could become accountable in terms of that care and do population health management. We became one of the very few large academic health systems to become a pioneer accountable care organization in the Medicare program as part of the Innovation Center, and we merged into the system a payer, largely a Medicaid managed care organization, to help us to have the tools to redesign care and to find the sweet spot in care management between payer and provider so that we weren't just faced with transactional prices in Medicaid that couldn't support our services, but we could focus around the patient to get him or her and their family the right care overall. Those were substantial moves and big changes for us. On the population health side, aside from the whole body of people in the insurance company, we have risk through our provider organizations for about 500,000 people in commercial, Medicare, as well as in Medicaid populations. And for us, that really requires a transformation and a redesign of care. And there are really 3 steps that we've taken in this regard. I think Greg started to talk with them. And the first of the major steps is on the population health side in redesigning the front end of care. Through experience in a project that was first led by the Mass General in a successful CMS demonstration project that was then extended to the rest of partners, we demonstrated that a new way of designing primary care for very sick people, for very risky people could in fact reduce their utilization, improve their health, reduce their mortality, and reduce costs in a substantial way. And the notion was to identify those very high-risk people, the 5% of us who consume 50% of the resources, or in Medicare, 10% who consume 70%, people on multiple medications who have numerous doctors. You know, I'm a geriatric psychiatrist by training. The way that I can basically figure out what's going on with the patient is to empty out the brown bag of medications that they come in to see me with. And unless we have perfect sharing of information, that's going to go on for a long time. So that fragmentation causes substantial cost and the potential for catastrophic utilization. And so we're first redesigning the primary care side, focusing first on intensive care management, redesigning them and making them patient-centered medical homes. The second phase is on the specialty side, embedding behavioral health services with primary care. People who consume psychiatric services have nearly double the overall consumption of general medical services because of the comorbidities that are associated with them. And frankly, as a psychiatrist, I must say how much we've reduced access to appropriate behavioral health services through stigmatization and underpayment. And at the same time, create real access to cardiology, dermatology, both in a virtual way, in an instantaneous or connected way, or in fact in a direct way. And also start to look at episodes of care that are around specialists and create bundled kinds of payments so that they have some skin in the game overall. And then finally, we'll move to real primary prevention. And that we can do with the population we're responsible for of the 100,000 of us and partners in our families who we're self-insured for. But you need stable populations over time to do true wellness, because you need to be responsible for people over a longitudinal period of time and have the right incentives to want people to do everything and to be able to manage exercise, appropriate diet, and a lot of wellness work overall. Sorry, you know, really I have a connected health problem. So connected health is really at the core of this solution. If we're going to figure out how to get the right care in the right place, if we're going to have to keep people from schlepping into the hospital, if we're going to prevent them from getting to an emergency room, and if we're going to connect them to the people who are managing their care, we need to know what's going on. So if we first we created a platform here, and I think as Joe is really the genius around, that platform brings together a variety of remote monitoring systems as well as patient-related data, brings it together through a remote monitoring data repository, and allows those data to be disseminated to the desktop for our clinicians as well as to our portal for our patients. So it promotes a higher level of interaction with one's own health, real-time knowledge, if in fact there are real-time data being provided, and allows us to start to create strategies that essentially allow us to manage care. So if we go to those high-risk patient populations, take our program I think that Greg started to talk about yesterday from the Connected Cardiac Care Program, and you know, anyone who is an internist will tell you that, the most substantial piece of their time is taken in trying to provide great care for people with congestive heart failure and diabetes. And congestive heart failure, which is highly lethal, is also now a chronic condition. And that chronic condition really requires really exceptional management overall and monitoring, because if something clicks in the wrong direction, if somebody gets sick and starts to retain fluid, if they start to change their diet or reduce their activity, or if they forget their medications, someone goes from being relatively highly functional and independent to essentially being near an ICU. And the Connected Cardiac Program is a perfect set of tools, monitoring essentially weights as well as blood pressure, and a variety of other symptoms, and then using those remotely generated data to provide for nurse monitors to be able to instantaneously know when somebody is beyond a specific threshold and an intervention is necessary. This is really secondary and tertiary prevention, and it's done in real time in a way that saves a substantial cost. And you can see the overall reductions overall in hospitalization in a cohort over a 4-month period of time before and after the use of this program. You know, essentially, there are a variety of great tools that are potentially available for good discharge planning. One of the problems we have is that hospitalization is so very expensive, but it's an episode in time. All the intensity and the focus doesn't look before, doesn't look after, and doesn't look well at being able to drive people forward and be able to manage their care effectively. And so this set of tools actually from a local firm called I Get Better takes really consumer-grade scales, blood pressure cups, other devices, and is able to load those those data into something that's useful, like an iPad, so that one can, in an ongoing way, provide monitoring data that also could be available to a data repository for patients as well. And as I mentioned before, diabetes is another giant area with the growth of obesity in the population, the risk for type 2 diabetes. The more we can do to help people manage their diabetes, the better. And Text to Move, which was developed in the Center for Connected Health and was put forward with funding from the McKesson Foundation, really is a paradigm that allows ongoing and instantaneous monitoring and coaching to allow people to stay within the bands regarding their sugar and be able to promote activity in a positive way and provide coaching so that people aren't on their own with their disease, again, promoting health in the context of illness. So this vision that we have is not just about primary care practices and academic medical centers and hospitals. It's around taking the venues where people are and making them perfectly seamless. And the notion of community hospitals are compelling to us because they're the closest entry point and anchor for most primary care doctors and keep people in their homes. One of the big problems we have in Massachusetts is also one of the great attributes of Massachusetts. We have magnificent academic medical centers and we have a small state. So it's relatively easy to get the care where you believe it's the best, whether or not you need that level of care. And the notion of being able to keep people near their primary care doctors with all of the utility of the ambulatory and other services of their community hospitals and have as necessary the great expertise or the use of academic technology and academic brilliance or the great specialty that we have in rehabilitation medicine or in psychiatry is the notion of a medical village as a center point with a perfect customer experience to be able to support that overall vision I described before. And one of the elements of having that system that I showed you being so siloed, and I know that there are various people who have various opinions about this, is trying to figure out how to have the data to know what our patients are doing in real time, to predict when utilization might be necessary or a problem exists, to analyze those data, to know what kinds of intervention and prevention are necessary, to know how to use those data to inform science in a major way, and also for providers to have instantaneous availability of data so they're not looking in a brown bag and figuring out which urologist to call who put somebody on a medicine that changed their cognitive function, which I pretty much had to do all the time. So our overall effort with Epic is more than really an overall effort with putting in a software with a software vendor. It's really a forcing function that allows us to standardize workflows in and around the system, standardize the kinds of remote devices in pharmacy that we have overall, as well as providing the data that we derive overall, and doing it all around patients so that they have instantaneous access. And the notion is really that each patient will have a single record, a single team that really is accounted for by that whole spectrum of services that we have and will allow us to manage both populations and referrals with a high degree of efficiency and effectiveness and use those data to inform better care, to create greater efficiencies, and to inform science. The scientific community is a fabulous tool for us. But most of the science that we've had in the system has been generated, like most biomedical science, NIH-funded R01s, which are very siloed and very low risk overall. The question is, how do we make certain that the tools that we have are able to translate science and catalyze it and improve it? Take the fabulous investigators that we have, put together the data I just described that are being collected in our clinical data repositories, bring them together with tissue data and the state of knowledge to be able to inform care and to help us to move in a diagnostic way from pursuing true negatives to pursuing very specific true positives and guiding the kind of care that we have. And some great work Sandy Aronson and others at Partners have done in working together at Gene Insight, which is really a real pathway-breaking joint venture that we now have with SunQuest to essentially make available state-of-the-art genetic data based upon essentially patients' own data and understanding and bringing to the electronic record a true understanding of the instantaneous relevance of those data. So we're going to collect genetic data, it's there, we know what markers exist, but we don't necessarily know how it applies to this individual, or if we collected those data before, what's happened in recent studies that would inform the care that we provide. And Gene Insight essentially provides really a world-leading genomic and personalized medicine, analytic and diagnostic set of capabilities that bring right into the electronic electronic record set of analytics using really an IT infrastructure that optimizes these data overall and allows each clinician to be informed by the state of the science in almost an instantaneous way. And we're hopeful that it will be path-breaking in this regard as well. So clearly connected health, putting together data, bringing all of us together overall, creating efficiencies are catalysts and tools that will allow us to transform from an illness care system to a healthcare system, to still preserve the magnificence of the great transactions that we can provide that translate science in a relatively instantaneous way to better care, and hopefully to continue to promote that, but additionally to manage populations in a way that has the greatest of ease, that is totally patient-centered, that demands effectiveness and improves the human condition. Thank you very much.
Thank you, Gary.